All right, good afternoon, everyone. Thank you for joining us for the afternoon session of the second day of the second session of the first day of the AHI Leadership Summit. Our theme this year is Uniting the Future of Population Health and Virtual Care. This is our 12th annual summit and our first ever virtual summit. My name is Courtney Shaler. I manage the Adirondack Rural Health Network for AHI, and I've had the pleasure of being on the planning team for the summit for the last 6 years. I would like to welcome you on behalf of our CEO, Eric Burton, our AHI Board of Directors, and our staff here at AHI. This afternoon's session, Putting DNA to Work for Patients, Genomic Population Health at UVM Health Network, is presented by Dr. Bob Wilden of UVM Health Network. We'd like to take a second to thank all of our past sponsors. We've been doing this event for 12 years, and we are lucky enough to have partnered with all these great organizations doing it. We do hope to be in person next year at Lake Placid so that you can enjoy our vendor hall and chat with our sponsors in person. I'm just going to go over a few best practice tips so you can get the most out of your experience with us today. Please confirm that you're muted and your video is off upon entry. To avoid audio issues, please choose either computer audio or phone audio. Using both may result in an echo on the line. For optimal viewing, we recommend using side-by-side mode. To activate side-by-side mode, click on View Options on the top of your screen and choose side-by-side mode from the drop-down. You can then click on Speaker, and then you can see the speaker only in video with the slides. We encourage you to use the chat freely to submit all questions, technical issues, and comments. The AHI staff will be monitoring it, and we will make sure to get to everything. On the off chance that we don't get to all your questions, we will follow up with you after and connect you with Dr. Wilden. Also, we want to let you know that all presentations will be archived on the AHI Conference's website by October 9th, both the slides and the recordings. I'm now going to stop sharing my screen, and I'm going to turn my screen over to Dr. Bob Wilden.
All right, I'm going to go ahead and share my screen and get it started. Thank you very much, Courtney, for the introduction and for the helpful technical comments. Are we seeing my screen now?
Absolutely.
Okay, great. I'll go ahead and get started. So thanks again for having me here to talk to this wonderful conference. And I wanted to talk about something that is probably not very familiar to many people, which is genomic population health and what we're doing at UVM Medical Center, UVM Health Network to do that. I am a medical geneticist. I'm a clinical geneticist and a laboratory geneticist. So I spend part of my time in the clinic and part of my time in the hospital laboratory doing work with genomic testing. So without further, let's see, there we go. So this is where we are housed at the University of Vermont Medical Center. The laboratory is about 2 floors below here, below ground here. And I just wanted to give that as a sort of reference point and talk a little bit about the laboratory. So the genomic medicine program and the laboratory was started about 2015 by Deborah Leonard up here, who came on as chairman of pathology and laboratory medicine. The primary thing that has been active in the lab since the beginning is somatic cancer genomics, which many of you will know is next generation sequencing testing of tumor DNA and RNA for prognosis and therapy of solid tumors. And we're going to add hematologic malignancies a little later this year. So leukemias and lymphomas and so forth. So as you know, there are many new therapies that are targeting the actual driver mutations in the genes that are causing unregulated growth in tumors. So we're doing that on a clinical basis, and that's precision medicine applied to the therapy of manifest disease. The second area that we're interested in is this genomic population health area. So the genomic population health is next generation sequencing, screening of unselected adults for hidden genetic disease and treatment risk, and that's what I'm going to talk about today. So we're genotyping, and the second component of that is genotyping for variants affecting response to common medications, so-called pharmacogenomics, and that's coming in the spring. I won't talk too much about that today. And overall, we're trying to detect genetically defined health risks, enabling management before the symptoms begin and the disease has a chance to take hold. So traditionally, medicine is responsive. So that's kind of the first part of the last slide was people who already have cancer, have a tumor and need to be treated. Of course, people in this audience know much more about this part of the picture, which is people who are healthy and for whom you can implement preventative care. So in this group of people, which is a random picture, of course, there are people who have genetic diseases that are hidden that they don't know yet that they have. There are people with hypertension. There are people potentially with colon cancer, for example. So the goal of our work that I'm going to talk about today is to identify those things at a time when they're easier to diagnose and easier to ascertain from a risk standpoint, and to do what we can to mitigate that risk and catch disease early. So when a patient comes to a provider for the first time, this is what the provider knows, basically nothing. So based on what they come in for, there's a light shown, there's sort of a circle of light, what kind of information is available to the provider and the patient to try to solve the patient's issue. So one of the areas that has not traditionally been included in that circle of light is the genetic information that you're born with, that you inherited from your parents, or sometimes you get new genetic changes in between generations. And there is now a significant amount of policy work that indicates that some of this information, we have enough information about the meaning of the genetic code to be able to use it for clinical purposes. And in fact, it's inappropriate to withhold that information if you know it. So this is just one of the types of information, of course, that a provider and a patient will consider in coming up with a care plan and managing their health. Unlike some of those other parts of information, the genetic information is relevant for the family because the family members have also inherited some of the same genetic information, or have transmitted it to you, or you will transmit it to your children. So it's a little bit different in that way. And I used to talk about that as the main, sort of unique thing. But in fact, the social determinants of health are really in the same position. So social determinants of health often affect a whole family unit in the same manner, or the same risks are present due to social determinants of health. So it's really not unique at all. It's something. It's just another way of looking at the same kind of information. And overall, we look at this effort as a way of incrementally improving the quality of the healthcare and the health of the people that we're trying to care for. So as that previous slide sort of suggested, our vision is that eventually everyone will have a genome sequence on file for health purposes only. And so our goal is to integrate the use of genetic information into usual medical practice in diagnosis, prevention, and treatment. And because we're one of the first groups to do this on a clinical basis as opposed to a research basis, we want to be able to demonstrate the value of genetics for health outcomes and for cost management for our 1 million patients, at least in the UVM Medical Center catchment area. So this is of the value proposition. This is the way I look at the value proposition. So this blue box is basically the population. It's everyone. And if we want to apply a population health screening, we're looking for a small number of people who have something. And so we try to get a low-cost screen, and we're looking for a population outcome, but also potentially an individual outcome. So if the few people who are actually discovered in the screen may down the line face a very high cost of care. So there's a prevention opportunity, and they have a personal outcome which, when caught early, may actually be quite different than if it was waited, if they waited until they had symptoms and active disease. So when you are screening for just one particular disease, all the effort of your screening process goes into the cost of that one disease, and basically the value of that of saving lives and healthcare dollars in that group is then spread across everyone. But if you multiplex that and do multiple disorders, then you have a cumulative benefit. In fact, with the next generation sequencing, it's actually incremental cost. So our concept is it's really the right way to do the population health screening is to not just do it one piece at a time, but to really try to find all the things that we can that are actionable in the genome with basically one testing procedure. There are complications to that, which is that then you have a bunch of widely different disorders, not all fitting into cardiology or hepatology or something like that to deal with. But from a total screening standpoint, that's a potential benefit. The other benefit of screening for genomics is that, as I said, it affects family members. So once you identify someone who has a variant for high risk, then their family members are also at potentially high risk. So there's additional value brought to the table for the family members as well. So what does it look like at the end? That patients and providers have more information about their health and their health risks. The timing is often before the onset of clinical disease and in advance of need. And importantly, that there are clear paths for making effective use of the information. And so one of the things I'll talk about in this talk is that we want to be able to use the information we have about the importance of these and know what we can and can't do with the information. We want to avoid doing a lot of excess testing that really isn't going to change how we're going to manage that patient after we find about their risk. And we want to make sure that they have the information for how they can deal with it in themselves and their family. So I just wanted to, as a geneticist, newborn screening is sort of part of my DNA. And this is an example of a population health test for genetic diseases. In Vermont, newborn screening is mandated by state law and detects 37 rare disorders, sometimes very rare, for which an established intervention exists that can change outcomes. There are disorders for which precision therapy exists, and saying targeting the biologic defect, and the one you're most familiar with recently is cystic fibrosis. But in fact, the original set of disorders that were screened for biochemical inborn errors in metabolism, the therapy for those are biologically based. So those really are precision therapies. They're disorders that require lifelong management. And they're disorders where the cost of care can be quite low, diet management, for example, to extraordinarily high, like the new drugs used for cystic fibrosis. The Vermont newborn screening test costs $203 per baby. So that's just kind of a reference point. Now, we've had to deal with some sort of what I call psychic barriers, so misconceptions or preconceptions about what we're doing. And one of them is that we're doing research. And in fact, the test that we're offering is a clinical test, and it's used in clinical care. We call it the genomic DNA test, and it's a gene panel, which means that it's a bunch of genes selected out of the genomic DNA and sequenced from there. And it's performed in a clinical laboratory, so the results can directly be used for clinical care. And the sequencing is done at a laboratory that does nothing but clinical genomic testing, and has a big infrastructure for interpreting the DNA variants, those DNA spelling differences from the reference genome, and figuring out which ones of them actually impart a disease risk or diagnostic of a disease. So that's what we're doing now. In the future, we want to move as the technology matures so that the sequencing the entire genome, or at least all of the genes that we know contributed to disease, which is about 7,000, can be done. And so that sequence will be sort of something that can be referred to for one's entire life. And that may come pretty soon. We don't have an exact date, but we're hoping that will come in the next year or two. The advantage of doing that is that you're not sort of looking only at those disorders which are more prevalent in the population, but you're also picking up ones that are rarer. And the rare ones individually are quite rare, but there are many of them. So there's an argument to be made that we're actually, by focusing on the more common ones, we're actually missing a big chunk of the picture. And so I think that's very important, and it's particularly important for people with rare diseases. And once that genome sequence is in the clinical record, then it is available for phenotype targeted queries, which means if you come in now with new presentation of something, it can be looked at rather than sending a new blood sample out to a laboratory to get sequenced again. You've already done that first step, and all you really have to do is the analysis. So when we began putting this together, we developed a set of sort of core implementation requirements. What do we really need to do to make this work? The first thing was to get system leadership on board. And I'll talk about all of these, how we went through all of these. So I'm just going to list them here on this slide. We're going to integrate with clinical care. In our case, we decided to do this through primary care providers because they're the sort of hub of preventative healthcare. That there's no economic barriers. So some of you may know that these kinds of tests are being offered through concierge medical practices or through executive clinics, and for people who can pay out of pocket for this. And there are a couple of problems with that. One is that that's inequitable, and the second is that the information we get about the outcomes from that group won't necessarily translate to the population at large, which is who we think eventually, if we can prove this, is going to become a routine part of care. So we required a lot of planning and oversight. We spent over a year with a care pathway working group that I led, and working with different partners, which I'll talk about, to pull together a variety of the pieces of this plan. The patient and the provider needed to have receptiveness and competency, so that's part of our requirement. Since we plan to scale this up to a population level, we really wanted to make sure that our implementation would be as best possible at this stage scalable. So we didn't want to sort of tie ourselves to things that wouldn't scale. And then the system that we implement would also enable learning, which is to say, can contribute to that knowledge base that helps us understand the information in our genomes. So that's the information that we have now. We have that knowledge base, but there's a lot of stuff we don't know. And so we want this to enable further learning along the same pathway. So we needed an engagement path to get patients aware of the test and what it meant. We needed the clinical sequencing and interpretation. We needed clinical informatics, the clinical care pathways, which are basically what does one do with the information responsibly, and clinical decision support in the traditional way, meaning that once someone has been identified as having high risk for a particular disease, how do you get them to the expert in your area who knows the most about that condition? So when we're talking about hundreds of conditions, no one is going to know everything about all of those. So we want the system basically, funnels people to the right kind of support. We have to have a lot of communication. We have to have a very strong quality mindset. We have to have some funding to do this. And we have to be persistent because this is something that's relatively new and involves a lot of moving parts and a lot of different parts of the health system. And so it takes a little bit of time. Oops, sorry, I jumped ahead a little bit there. All right, so this slide is about our partners. One Care Vermont is the accountable care organization in Vermont. And I'll talk a little bit more about how our partnership with them developed. Invitae is the clinical genetic testing lab that we partner with to do the actual testing and report generation. And Luna DNA is a very interesting organization that basically functions like a broker between individuals with genomic and health information that's linked and researchers who want to study it. And I'll talk more about that later. The Luna DNA is an option for patients. It's not a requirement. It's not part of the test, but it's an option that we think is very important to provide. And then the fourth partner here, of course, is our family medicine primary care providers who are our pilot offering the test. So I'm going to jump back to the point about engaging leadership. So when Deborah Leonard came on board, I think in 2014, she had this vision already in her mind, and she worked to get about 70 people in our systems, so system leaders and staff, to actually get 1,200 of their own genes sequenced in a clinical manner, and to learn from that what patients would be going through and what the potential value is. And of course, there was at least one life-changing result, and there were several clinically important results on top of it, including individuals who learned that although they had a family history of something genetic, they actually had not inherited it. So one example of that was written up in Eleanor Osborne's Getting Personal story in Vermont Medicine magazine, which appeared earlier this year. There's a link here. It's a really great article. I strongly recommend that you check it out if you're interested in sort of these stories that help explain and put some context onto the sort of technical talk that I'm giving. And this is Deborah Leonard, our chairperson, who's explaining to him that he didn't actually inherit the genetic risk in his family. So the second partner that we had was the Accountable Care Organization. So we decided, as I said, to go with a zero cost for the test, and we're also throwing in most of the genetic counseling as well. And it turns out that you can't offer something for free in medicine without running afoul of some rules. And so we had to get a care innovation waiver from One Care Vermont to do that. So that was a great benefit, that we could continue on our plan of making cost not be a barrier for this test at present. And then, of course, for the long-term impact, we want cost and outcomes analysis in One Care Vermont. It has the ability to aggregate the information and be able to provide that kind of analysis long-term. So the next partner was our primary care providers. And we know primary care providers are extremely busy. They don't have a lot of time to spend with patients. They're not geneticists, they're not genetic counselors, they're really not genetic experts on many counts, and we shouldn't expect them to be. But they are the sort of seat of preventative care and of stability across one's healthcare life. And so we wanted them to really be at the center. In order to do that effectively, we had to make sure we had a lot of help for them. We created a Genomic Medicine Resource Center, which is basically myself and a genetic counselor, Christine Jumeau, which could be queried either by the providers or the patients with any questions about the program. We have result-specific guidance that is presented in the form of a 1 to 3 page action plan I'll talk about in a moment. We have education opportunities for the providers. And in fact, the GMAP, this result-specific guidance, I think has functioned as a significant amount of education for the providers as a sort of stealth mechanism. And we had already identified specialists and developed these care paths for several different types of diseases. We create smart phrases for EPIC reports, EHR sets, and so forth, so to facilitate their workflow. And we have, of course, our local genetics professionals in several areas that are on board. So just as to give an idea of the breadth of the clinical pathways that, that we worked on to integrate this into patient care, first was identifying patients and educating them about the test. Obtaining clinical informed consent in Vermont requires a written informed consent for genetic testing, and we worked to create a specific informed consent that was included, the people who put it together included the patient family advisor panel. So we had a lot of input basically from the community about how to make this clear and effective. We need to be able to obtain and ship the specimen and perform the genomic test and report interpretation. We need to integrate that result into the EHR so the providers who take care of that patient have access to it. We need to be able to explain to the patient what this means genetically for them and their family as needed. And we need to guide the primary care providers and work with the specialists to coordinate their care. And then the family members who may also be at risk can get cascade testing, which is, if somebody in the family tests positive, then other members who may also have inherited the same thing can also get tested to learn their status. And then we also incorporate multidisciplinary conferences to learn from our process, understand the stories, how the patient and provider experience is going, and optimize care over time. So the care pathway partners that we put together were cardiology, oncology, pulmonary and anesthesiology, pharmacy for the further down pharmacogenomics component. Medical ethicist was on our care pathway working group and was instrumental in helping us make sure we didn't approach any ethical concerns in the wrong way. And then we have healthcare value experts as well. As I said, in our care pathway working group, we had patient and family advisors. So so the laboratory is involved because the laboratory processes the samples and has to ship them out to the reference laboratory and bring the information back in. There's a lot of information that has to flow back and forth, and much of it is in electronic format. The researchers are contributing the information, the knowledge that helps us make clinical use out of this. These 3 photos are actually stock photos. They're not people in our system that I know of. This one is some of the patient and family advisors in our hospital. They're not the ones that helped us, but just to give you a sense of how that goes. This is literally what we did. We sat around tables and explored how we were going to do this. 3 providers were instrumental, in particular Aaron Ryder, a family medicine provider who really was sort of instrumental in helping guide that and pulling things together, and also pulling other providers in to be interested in this. Marie Wood is our genetic oncology consultant, and Daniel Correa de Sa is our cardiology consultant. And it's fair to say we actually supported a small portion of each of these people's salary, so that we weren't expecting them to do this, gratis. People are really overworked to start with, and so you have to, give them something of value for what you're asking, and it was worth it. So what is the test itself? The genomic DNA test is a test for genetic differences that can cause diseases in the tested person or their family members. All right. So because we were sort of buying this off the shelf, we ended up having 2 separate panels that are gene panels that are what we put together and call the genomic DNA test. The first one is the proactive health screen. It's 147 genes for health risks that I'll describe moment to moment. If someone has a positive result on that, any of their blood relatives can get free testing within 90 days. During COVID, that's been expanded to 150 days, but the basic policy is 90 days. Invitae comprehensive carrier screen is the second panel. It's 301 genes for recessive disorders. So disorders that if you have that genetic change, you only have one, and you only have one copy of that. You have another copy of the same gene, which is normal. then you're not affected by that disease. But if you inherit two altered copies, one from each parent, then you can have a disease. So in the case of the carrier screening, if you have a positive for that, you can get low-cost partner testing for the variants that you found for $100. There are a total of 431 genes, which is less than the sum of those two. That's because some of the genes are reported on both panels. In the future, we want to add the pharmacogenomic variation, drug-gene interactions, and also, as I said before, we want to move toward from the panels to sequencing the entire genome, the clinical genome, in place of the panels. There's something that you may have heard of before called polygenic risk scores, which has started to appear in the literature in the last 2 or 3 years. And we're not planning on that right now. There are some, it's a really promising area, but there are some complications to it. I think we'll get there. Once we get to genome sequencing, we'll be able to do more of these kinds of things. And so that's certainly on the docket. And what this will do is basically say, if you have a lot of different small variations that incrementally increase your risk, say for diabetes, heart disease, or breast cancer, this score may actually help us decide who needs more intensive screening. All right. Importantly, variants of uncertain significance are not reported. Now, what are variants of uncertain significance? So anything that is different from the reference genome when we sequence genes is considered a variant. And variants are classified as pathogenic, likely pathogenic, likely benign, or benign. And if we don't have evidence that they fit into any of those 4 categories, enough evidence, then we call them a variant of uncertain significance or a variant of unknown significance. Because in this screening paradigm where the patients that we're testing don't have an increased probability for any of the disorders that we're looking at, the variants of uncertain significance really have no value. There's no clinical value, and you can chase your tail around in circles trying to figure out whether they're important or not. And in some cases, they've been misinterpreted, and people have had surgery to remove organs that they didn't need to have removed. So we're eliminating the reports of variants of uncertain significance until sufficient evidence is present that says that they're important. Okay. So the health risk panel, just to give you an idea, is really broken up. The genes are broken up into 3 groups. The blue group here is predisposing to neoplasm, so breast and GYN, colorectal cancer and GI cancers, skin, endocrine, nervous system, renal, and urinary tract. And that's almost half. And then another half is cardiomyopathy, arrhythmia, aortopathy, hyperlipidemia, thrombophilia, and bleeding disorders. And then there's a little wedge of other disorders that don't fit into those 2 categories: hemochromatosis, alpha-1 antitrypsin deficiency, ornithine transcarbamylase deficiency, which can be expressed in carrier females, and malignant hyperthermia, as well as Wilson disease. So all those, most of those are actually recessive, and that's why there's gene overlap with the recessive gene panel. All right. So how does the patient learn about this test? This is Christine Jumo, laboratory genetic counselor, who's really been my partner in pulling all this together. And she is holding up a little folder, which we call the patient packet, and it contains the patient information for that the providers give to the patients. We also created a brief animated video, which I'm going to play right now, and it's 1 minute and 46 seconds long. So without further ado.
Your health is determined by many things. One important health factor is your genetics. Your genetic information is stored in your DNA. Your DNA
Dr. Wilden, we can't see the video.
running your body. DNA differences
okay, hang on.
make it. Your health is determined by many things.
Okay, sorry, I needed to share the right screen. Sorry about that.
No problem. Just want to let you know.
And let me share. Right. We did this in the test, didn't we?
We did, yes.
Health.
I don't know why that is showing. Let's try this.
So the best bet, Dr. Wilden, is to stop sharing your screen
Okay, got it.
and reshare the video screen only.
Okay.
And you'll have to flip-flop back.
Thank you, Kate.
It's a bit of a
All right, okay.
Your health is determined by many things.
Okay. All right, let me do it with the screen. Sorry about that. And then we'll flip back to this.
Your health is determined by many things.
Better?
There you go. Now we can see it.
Important
Yeah.
health factor is your genetics. Your genetic information is stored in your DNA. Your DNA is the instructions for making and running your body. DNA differences make us different from one another, and sometimes DNA differences can cause diseases. The University of Vermont Health Network wants to give the best healthcare possible. So we are offering to look at your DNA and use that information for you and your family's medical care. Your healthcare provider can order this test for you. If you decide to have this DNA test, we will use a small amount of your blood to test for DNA differences that could lead to cancer, heart disease, and other problems. It also looks for differences that may affect your children and other family members. The test will focus on the parts of your DNA that most affect your health and healthcare. The test results will go into your health record and be protected like all your medical information. Your test results will be available to you and all your providers. Our knowledge of DNA differences and how they cause diseases will improve over time, so we may be able to update you and your providers about medically important DNA differences in the future. There is no charge for the testing or for getting your questions answered. The test is optional. It's your choice. We understand you may have additional questions. Your provider's office can direct you to more resources to answer your questions. If you choose to be tested, please review and sign the informed consent that says you agree to have this test. Remember, this is a new way to guide your medical care that may benefit you and your family. At the University of Vermont Health Network, better healthcare happens in partnership with you. We thank you for considering this DNA test.
Okay. Good. All right. So that's a video which can be shown, in the clinic office if necessary. Our patient family advisors ask us to make sure we had sort of a layered approach to information, because some people like to consume smaller amounts of information, other people like a little bit more detail, and some really like to dig into it and get the most information they can. And so we have that with the video, a trifold brochure, and then a 6-page frequently asked questions document. Also in the patient packet is a list of the genes that we're testing, and the informed consent form is also a next step. So after they've been consented and the test has been ordered, how do they go about getting their blood drawn, et cetera. And then there are some forms for providers having to do with the send out test, and we're trying to get rid of those as best we can. All right. So all of this information is now on a website, and the yellow arrow here points to the places where all those documents can be downloaded by the patients. And the video is right there on the website as well. So we're working toward, so this actually was sort of pushed through as a result of COVID, because the primary care providers weren't seeing patients in person. And we wanted them to be able to refer patients to a website where they could look at the information themselves and decide if they wanted to do the test there. So who is eligible to get the test? Of course, we want the provider and their staff to be trained to be able to do this. And we emphasize in the training that they don't have to answer the questions about the genetics in the test. They refer that to us in the resource center. That's worked really quite well. Patients are adults 18 years or older. We will be moving to pediatrics eventually, but there are some different ethical and different gene panel choice differences that apply for the pediatric population. So they have to be a covered life under the Vermont ACO, and I described before sort of our desire to capture all of that cost and utilization information under that system. And then they are not pregnant and their partner is not pregnant. The only reason for that is because there are specific tests for carrier testing during pregnancy that have a short turnaround time. And as you know, having tests about new information, surprises coming up during pregnancy is not necessarily well received. And if we had to scramble because of a longer turnaround time, we'd be in big trouble. So that's part of it. People who are pregnant can finish their pregnancy and then get the test. So the other thing, sort of psychic barrier we've had is that people say, okay, well, it's a genetic test. So we use this, if I have a patient who's got a family history of cardiomyopathy, then I should get him this test, right? Actually, no. So this is, the assumption is that there's no prior probability in the person who's getting the test. If you have a prior probability on the basis of personal or family history, then you need to use the usual diagnostic testing and evaluation system. So this is not really replacing diagnostic testing at this time. So how does it work in practice? For the patient, they review the information, ask questions, sign the informed consent form, get a blood draw, get a call from the primary care office with the results, receive printed results in the mail, and get offered appropriate genetic counseling. It's really up to them to drive that and for the providers to drive that as well. For the primary care provider and staff, they identify the eligible patients, introduce the test at the visit using the information we just went over, refer genetics questions to the Genomic Medicine Resource Center, complete paperwork and order, and review the results, print and mail them to the patient, and have appropriate discussions of the results. Some results, if you're just a carrier or past reproductive age, there's not much discussion unless you want to talk about what your children's risks are of being a carrier as well. Order follow-up actions and document. So in a lot of ways, this is really no different than what you do for, say, prenatal screening tests that you do for a woman who's pregnant, right? So the workflow is really quite similar to that. Obtaining a DNA sample, we get 2 tubes of EDTA, and then we offered, during the COVID process, we added the option of a saliva collection, and Invitae will ship a saliva collection kit, which is kind of a cute little thing and comes prepaid return postage. It's good instructions and a video online you can look at to collect saliva. So that was one of the adaptations we made for the period when everything was being done by telemedicine. It's still there. How long does the test take to result? Typically three weeks, but we tell patients about a month, so we have time to process the results. The results are stored in the EHR, and therefore they are covered by HIPAA. So we feel that's as strong a protection as we can provide for those results without reducing the clinical usefulness of the information. What do the results look like? So the top 2 pictures here are the Invitae reports. There's a comprehensive carrier screen and the proactive testing results, the health screen results. And they come in they look at it as 2 separate tests. So they come in 2 separate reports, which are multiple pages long. We take the information in those and turn it into condense it into a set of messages called the Genomic Medicine Action Plan.
Dr. Wilden, I don't want to interrupt you, but we've got some questions piling up in the chat, and it is 2:45, so maybe 5 more minutes, and then you'll take a few questions.
Okay, sounds great. Thank you.
Thank you.
So the action plan is basically a set of messages, and there is a column for the patient, there's a column for the provider, and they're basically broken into what to do now with this information, what to be aware of going forward, so continuously useful information, and what you might want to come back to later, because sometimes there's something that isn't relevant right now, but it might be relevant for you later. What does the PCP office do with the results? So this is basically triaging who handles what kind of results, carrier tests only, negative, negative, positive health risk result, and the provider gets involved as opposed to the staff. And then complex results, the Resource Center for Genetic Counseling. Just a couple of the main pathways that we developed. Our cancer risk pathway, if there's a positive cancer risk test result, it's very simple. We refer to the existing familial cancer program at UVM Medical Center. And they have genetic counselors, they have genetic experts, cancer experts, and so they're kind of a one-stop shop. So it's really quite simple for us for that. For the cardiologists, they don't have a familial operation, they don't have genetic counselors. So we split things into referring for genetic counseling where they get a detailed family history that then the cardiologist can use in their evaluation. And depending on the particular result, the primary care provider may execute a pathway, a care pathway that says, go ahead and get an EKG before they go to the cardiologist. Sometimes that may avert the visit, or it may provide information that helps the cardiologist make better use of the visit time that they have. So there's new evidence, drives new value. I talked about that earlier. So when a variant that was previously classified as of unknown significance or of likely pathogenic gets upgraded, say to pathogenic, then a new report will get pushed out and we'll push out a new GMAP and get to the patient. We emphasize that because patients may move on and not get their care in the system anymore, they need to take responsibility every couple of years to talk to their primary care provider wherever they are and say, let's get an update on this information. I'm going to skip the part of learning in healthcare systems. I think this audience probably knows that. Basically, we want to do, enable genomic variant research to make more value for the information in the genome, precision therapy research, genomic value research, and implementation research around, what's actually working, what do we need to do, and what are we missing, and then the system components. We have the opportunities for learning and research, business intelligence type things, the health value with the ACO, the Luna PBC, and I'll go about that in a moment. It's basically a broker between individuals and interested researchers. There is also always the possibility to do IRB type research. I want to study this patient population using direct EHR data, et cetera. And our partners in the genomic value research are in the Center for Health Services Research at UVM, as well as those in the ACO. So Luna DNA, basically you contribute your, voluntarily, you consented for this, contribute your DNA information and your health history into Luna DNA's secure database. And then Luna DNA lets researchers know that the information exists. If they want to use your data, they'll ask your permission first. And then I'm going to jump down to the bottom here. You actually earn ownership shares in the corporation for the data contribution and the benefit of the value. So if Luna DNA makes money from researchers paying to get to the information, you actually have equity in that. Our near-term goals are to provide complete 1,000 patient pilot by the fall of 2020. Obviously with COVID, Christmas and chaos, that's not going to happen. We have a long-term plan to test 50,000 patients over 5 years to assess the genomic value for healthcare at that point, and then to continue if appropriate. So let me just talk about the results really quick. We have 3 sites, 9 providers.
Dr. Wilden, it is 10 of, and we have 4 or 5 questions in the chat.
I have 2 slides, 2 more slides.
Okay, perfect.
Yeah. So that just basically shows that COVID had a hit on our throughput, and we have only had 76 so far. The median age is around 60, which is a bit older than we'd like, but it reflects the age distribution in the clinics that we've been collecting. So here's the results. Here's this results summary of what we've had so far, 76 patients. Only about 1/5 have not had any variants discovered at all. So that means about 80% have had some variant, whether that be a carrier status, not affecting their own health, but potentially important for their children. And patients, variants that place the tested person at increased risk was 17%, or 1 in 6. So if you ask yourself, what's the frequency with which people in your practice have hypertension discovered by blood pressure screening. It's probably on the same order, right? So this is really something that has a potentially important impact on health risk. And then just to give an idea, we had 136 unique variants identified for about 1.8 per individual. Here's the disorders that were detected, and I don't have to go through all of these. The ones on the left are dominant. If you only have one genetic variant, you're at risk. And most of these are cancer, bleeding or clotting disorders, a Z allele heterozygote for alpha-1 antitrypsin deficiency, etc. And then one person who may have atypical cystic fibrosis, not previously diagnosed, primary ciliary dyskinesia, G6PD deficiency or favism, and a 3 with hereditary hemochromatosis type 1, which is not surprising. It's really a quite common disorder. All right, so questions and discussion. Sorry about rushing the end.
Oh no, I'm sorry we didn't have more time for you, but I know you're gonna want questions. The first one is, are the pharmacogenic variation panels based on drug metabolism?
So yeah, most of them are pharmacokinetic and not pharmacodynamic. So they are basically the ability to convert a prodrug into an active drug, and whether you do that too slowly or too quickly can affect the impact of the actual active drug. And also the rate of degradation of the drug or the rate of elimination of the drug. Yeah, so that's mainly what we're talking about.
Okay. The second question is kind of a two-parter. Can you speak about data retention / ownership protocols? And then this person has a second part of the question, but I'll let you answer the first one first. So can you speak about data retention and ownership protocols?
Yeah, so it's a clinical laboratory, so it's kept according to requirements for clinical laboratory data. It's in your EHR as permanently as that is. The laboratory that does the testing also is under CLIA requirements, and they keep the data as well. The performing laboratory Invitae has the attitude that the information is yours, it belongs to you, and they use it in aggregate information, but they don't sell the individual information attached to the individual.
Okay, thank you. This person, also you mentioned a varying cost of care in the future. Is there an estimate of the overall expected cost of care across all conditions, i.e. the net economic effect?
Yeah, so we don't have that data because no one's sort of done this before. There are some places where this was started in research about 5 years ago, and they're beginning to collect that information. The Australians are actually kind of keen on this, and they've done some modeling. The modelings predict there's long-term cost benefit, at least in the Australian healthcare system.
Okay.
And there are, for individual disorders within the groups that we're looking at, there have been some studies that show that yes, this is worth doing.
Okay, thank you. This one came in at the beginning. How common is newborn screening? You mentioned that in the beginning of your presentation.
So the newborn screening is something that's required by the state for every newborn to get. So before they leave the nursery, or if you have a birth at home with a midwife, the midwife is required to come back and get that blood spot sample that's sent off to the state contracted lab to provide that screening. So it's in every state in the United States does that. Not every state does exactly the same panel, although there's been significant movement in the last few years to unify so that most states have it. So there's a federal actually recommended panel, minimum recommended panel that's out there.
Okay, thank you. And this one, is this program leveraging telemedicine technology at all? And if so, how? If not, are there any use cases for consultations to be done virtually?
Yeah, so that's a really good question, and I meant to touch on that. But so the providers, the primary care providers, when they switched to doing telemedicine during the COVID lockdown, we provided the website and we provided the opportunity to do the saliva kit testing. So, and they're continuing to do, 20, 30% telemedicine, I think. So, so that's still completely a possibility. This can be done completely by telemedicine. The second part, I think, is the genetic counseling that goes along with it. The genetic counselors in our system, in the pediatric and adult area, cancer area, and the laboratory, our Genomic Medicine Resource Center, have all been doing telemedicine for several years now for genetic counseling. So that's something that can definitely be done by telemedicine. So we're really, in a pretty sweet spot. What can't be done are physical exams, things like that. I mean, one can take a family medicine of using family history using telemedicine, but you can't, feel for an enlarged liver or something like that.
Excellent. Thank you very much. Dr. Weldon, thank you so much for this informative presentation. Did you have any closing thoughts you want to leave us with? And I'll let people know if you have a last-ditch question, please get it into the chat.
Great. No, I think I'm just really excited to have this opportunity to share what we're doing, and share I think the way I look at it is a lot of success. We've actually implemented something that's quite complicated from a system standpoint, and our biggest barrier is COVID at the moment. Is the moment in terms of moving forward. So I think that's where we're at now. In the future, after our 1,000, we have funding for our 1,000 patient pilot. Getting funding after that is something that's going to be a challenge for us. We look forward to finding ways to do that, and basically letting people understand that genomics can be really an important part of healthcare.
Excellent. Thank you to everyone for joining us today. And again, Dr. Weldon, thank you for your presentation. Those of you that maybe hopped on late, we did want to stress that the presentations, the slides themselves, and also the recording will be up on the AHI Conferences website by October 9th. Thank you all so much for joining us. Have a good afternoon.
Thank you all. Thanks.
Bye, everybody. You're welcome. Thank you.